Hey everyone, I'm going to be discussing placental abruption. I'm going to talk about some general features, the clinical assessment, diagnosis, and then treatment and prevention. So, to start out with some general features, placental abruption is defined as the complete or partial separation of the placenta from the uterine wall prematurely. So, what happens is you get damage to these maternal vessels, which you can see here in the picture, and that damage causes bleeding between the decidua basalis, which is actually the maternal component of the placenta, and the anchoring chorionic villi, which can also be seen here in the picture. So when you get the bleeding between those two spaces, that actually causes the placenta to detach from the uterine wall. Unfortunately, the etiology is not completely understood and thought to be multifactorial. So, while a small number of cases of placental abruption can be attributed to mechanical trauma leading to shearing of these vessels, most abruptions appear to be related to factors that induce decidual ischemia, leading to necrosis and then bleeding. And some complications you'll think about that could impede the uterine blood flow include things like impaired placentation due to a uterine anatomical abnormality, or you may have a patient with thrombophilia or hypertensive disorders. And then some other things would be like vasoconstrictive agents such as smoking and cocaine. Placental abruption complicates 0.5 to 1% of pregnancies in the US, which you hear that and you think that's not too many, but it is actually the leading cause of perinatal mortality. The incidence of placental abruption in the US is increasing as the prevalence of risk factors continues to rise. And some of these risk factors are if the patient had a previous abruption, multiparity, if they have hypertension, if they smoke cigarettes or have used cocaine, low socioeconomic status, poor nutritional status, and then extreme maternal age. So they actually found that patients younger than 20 and then older than 35 years old actually had an increased risk of placental abruption. And two interesting facts is every pack of cigarettes smoked per day increases the risk of placental abruption by 40%. And then women using cocaine in the third trimester of pregnancy have a 10% risk of placental abruption. The clinical presentation for placental abruption is highly variable, but the most common presentation is vaginal bleeding after 20 weeks of gestation. So, anytime you have a patient coming in with vaginal bleeding after 20 weeks, placental abruption always should be high on your differential. Other signs and symptoms could be abdominal pain, frequent uterine contractions, and then maternal hemodynamic instability. And on your physical exam, you may notice hypertonicity of the uterus, may have abdominal and uterine tenderness to palpation, and then you may even notice increasing fundal height, and this would be due to the accumulative hemorrhaging. And then fetal heart rate abnormalities such as prolonged bradycardia or repetitive late decelerations are also common findings with placental abruption. Although the diagnosis of placental abruption is primarily clinical, some studies can be utilized to support the clinical diagnosis. A retroplacental hematoma seen on ultrasound is a classical finding, but unfortunately, the sensitivity of a diagnostic ultrasound is only about 25 to 50% due to the variable size and echogenicity of the hematomas. And usually, with an acute abruption, you're actually going to have a hyperechoic area on ultrasound, and this is difficult to differentiate from the placenta itself. And then you're also going to have other hypoechoic areas such as uterine contractions, which can also be mistaken for placental abruption. But placental abruption should not be ruled out due to the absence of a hematoma seen on ultrasound. And here with this ultrasound on the slide, this is actually showing a posterior placenta with a large retroplacental hematoma shown by the yellow arrows. And then MRI is highly sensitive for placental abruption, but it is not a practical diagnostic study just due to the acute onset of an abruption and the high cost of the MRI. And then, unfortunately, placental abruption is only definitively diagnosed by pathological findings following the delivery of the placenta. For treatment of placental abruption, if the fetus is less than 34 weeks gestation, the goal of treatment is conservative management with antenatal corticosteroids just to prepare for preterm delivery of a more mature fetus. And then if the maternal or fetal status begins to decline due to massive hemorrhaging, emergent cesarean delivery is the optimal management to facilitate rapid delivery and then control the bleeding. If the fetus no longer is living secondary to placental abruption and the mother is stable, vaginal delivery is actually preferable and allows for a quick delivery due to the hypertonicity of the uterus and then the forceful contractions. Placental abruption is not directly preventable due to its unknown etiology and acute onset, but many reversible risk factors can be avoided to decrease the likelihood of an abruption through patient education. If a patient undergoes any form of abdominal trauma, they should always seek immediate medical attention due to the increased risk of placental abruption. And then also, ultrasound screening should be utilized to detect any placental or uterine abnormalities, such as uterine myomas that could predispose a patient to placental abruption. And that is placental abruption. Here are my references, and thank you for your time.